Namaskar and very good evening to all of you. Welcome to the day two of webinar on optimizing treatment outcome in lung, breast, GI, and GU cancers. It's my immense pleasure to invite Dr. Gunjesh Kumar Singh. He's senior consultant medical oncologist at Paras HCC Ranchi. To welcome and welcome to Dr. Gunjesh.
Thank you so much. Thank you so much for the kind introduction. So today we are here to complete our 2 days webinar session regarding updates in lung cancer, breast cancer, GI and GU cancers. So yesterday we have discussed lung, breast. So today we will be discussing regarding GI malignancies mostly and GU. So thank you so much, all my colleagues, my seniors from various states who have spared time for this meeting and made this event successful. So thank you, Team Horizon, for conducting this and managing this webinar so smoothly. So thank you so much, everyone. So let's start with the first speaker and handing over to the management team for further coordination and everything.
Thank you so much, sir. For our first talk on GI cancers, I would like to invite Dr. Abhishek Anand. He is senior consultant and head of Department of Medical Oncology at Paras Health in Patna. He will be speaking on ASCO 2025 outlook in GI cancers. Over to you, Dr. Abhishek.
Thank you, and thank you, Gunjesh, for inviting me for this webinar. So I'll be discussing on ESCO GI updates that was presented at the 2025 annual meeting of ESCO. So we'll be discussing about three important abstracts that were presented there. So start with the first abstract. It was a atomic study and it was a late breaking abstract one. It is a randomized trial of a standard chemotherapy alone or combination with atezolizumab as adjuvant therapy for patients with stage 3 deficient DNA mismatch repair, that is DMMR colon cancers. Key takeaway points from this trial was FOLFOX or CAPOX has been the standard of care for adjuvant therapy in all stage 3 colon cancer, and adding atezolizumab to modified FOLFOX6 significantly improves disease-free survival for DMMR stage 3 colon cancers. Chemoimmunotherapy so now represents a new standard treatment for DMMR stage 3 colon cancer based on this study. Background standard adjuvant chemotherapy for stage 3 colon cancer with node positive consists of 5-FU oxaliplatin, that is regardless of MMR status. Around 15% of colon cancer have deficient MMR and may display resistance to fluoropyrimidines. Despite adjuvant chemotherapy, approximately 30% of stage 3 patients will experience recurrence of their cancer. While approved for DMMR metastatic cancers, it is unknown if an immune checkpoint inhibitor will improve outcomes after surgical resection of DMMR stage 3 colon cancers. This is the study design of an atomic trial. It is a randomized multi-center open label phase 3 study, and patients aged more than equal to 12 years histologically confirmed R0 resected stage 3 colon cancer were enrolled, having DMMR by IHC. Randomization was done 1:1 to receive modified FOLFOX6 along with atezolizumab for 6 months, followed by atezolizumab maintenance for another 6 months, that was given every 2 weeks at a dose of 840 milligram. It was compared with modified FOLFOX6 and it was given for 6 months. Primary endpoint of this trial was disease-free survival and the key secondary endpoints being overall survival and adverse events profile. This is the statistical methods. Target hazard ratio of 0.6 was defined before starting the trial. It was predefined, and 3-year DFS of 84% versus 75% was predefined with a one-sided alpha error of 0.025 and 90% power. First patient was enrolled in October 2017 and accrual was closed in January 2023. The study randomized 712 patients altogether. This is the console diagram, and in arm 1, that was modified FOLFOX6 along with atezolizumab, 355 patients were enrolled, and in the arm 2, that was modified FOLFOX6 alone, 357 patients were enrolled. Baseline characteristics of the two subset were almost equivalent, almost normal. And here you can see the median age was 65 years in modified FOLFOX6 along with atezo arm, and it was 63 years in the modified FOLFOX6. Stage-wise, T4 stage was present in 31.5% of the patients who received atezo and 31.9% in patients who received modified FOLFOX6 alone, and to disease in 36.3% of the patients receiving atezo arm and 37.0% in modified FOLFOX6 alone arm. Median treatment duration was 5.5 months for modified FOLFOX6 in the FOLFOX6 along with atezo arm, and for atezo it was 10.9 months. In the mFOLFOX6 arm it was 5.4 months. Coming to the primary endpoint of this trial, that was disease-free survival. At the end of 3 years, the DFS rate was 86.4% for those who were enrolled in the atezo arm along with mFOLFOX6, and it was 76.6% in those who received modified FOLFOX6. So it was statistically better for the atezo along with modified FOLFOX6 arm as compared to the modified FOLFOX6 alone. DFS results based on DMMR by Central Reference Lab. Again, it was better for atezo arm as compared to the modified FOLFOX6 alone. DFS by subgroup analysis, all the subset favored atezo along with FOLFOX6 combination as compared to the FOLFOX alone, irrespective of age, sex, race, tumor location, T or N stage as well. Overall survival data are not mature at this time. Median OS follow-up is 42.5 months at present, and the OS comparison may be confounded by subsequent immunotherapy. Safety-wise, any grade adverse events were seen in almost all the patients who were enrolled in the atezo arm, and it was in 95.1% in the placebo arm. Grade 3-4 adverse events were seen in 83.8% of the patients in atezo arm and 69.1% of the patients enrolled in the FOLFOX6 alone arm. Common side effects which were seen in the trial were fatigue, nausea, peripheral sensory neuropathy, neutrophil counts decreased, platelet counts decreased, diarrhea, anemia, anorexia, abdominal pain, constipation, and decrease in the WBC and altered LFT profile. Immune-related adverse events were seen commonly in the atezo arm as it was expected, with common side effects being or the immune-related adverse events being adrenal insufficiency, hyperglycemia, hypothyroidism, colitis, myositis, and dermatitis. Conclusion of this study was that atezo along with mFOLFOX6 demonstrated a statistically significant and clinically meaningful 50% risk reduction in recurrence or death over mFOLFOX6 alone. The safety of mFOLFOX6 plus atezo was in line with the known safety profile of each, with a manageable increase in the non-febrile neutropenia. Atezo plus mFOLFOX6 is a practice-changing treatment for patients with dMMR stage 3 colon cancer. Coming to the next important trial that was presented at this ASCO 2025 annual meeting, and it is the Matterhorn study. It is a randomized phase 3 study of durvalumab plus 5-FU, leucovorin, oxaliplatin, and docetaxel, that is the FLOT regimen, in resectable gastric or gastroesophageal junction cancer. Key takeaway from this study was that the addition of durvalumab to FLOT improved the event-free survival in resectable gastric and gastroesophageal junction adenocarcinoma. Little bit of background: around 1.2 million people die of gastric and esophageal cancer in 2025. FLOT chemotherapy has been the standard of care in the peri-operative setting for localized or locally advanced gastric and GE junction adenocarcinoma. Adding anti-PD-1 therapy to chemotherapy improves survival in metastatic gastroesophageal adenocarcinoma, and its role in peri-operative setting, however, remains uncertain. Matterhorn study evaluated whether adding durvalumab, which is a anti-PD-L1 antibody, to FLOT regimen improves outcome in patients with resectable or localized gastroesophageal adenocarcinoma. This is the study design: global phase 3 randomized double-blind placebo-controlled study. Patients enrolled were of gastric or GE junction adenocarcinoma from stage 2 to 4A without any evidence of metastasis and without any prior therapy. Randomization was done 1:1 to receive either durvalumab along with FLOT for 2 cycles in the neoadjuvant setting. It was compared with placebo along with FLOT for 2 cycles, and it was followed by surgery, and then either durvalumab plus FLOT or placebo plus FLOT for another 2 cycles, followed by durvalumab maintenance for 10 cycles in the durvalumab or the trial arm. The primary endpoint being the event-free survival, and the key secondary endpoint being overall survival data and the pathological CR. This is the statistical endpoint and definition, which was predefined. Participant disposition at the time of data cutoff: all the patients received durvalumab and FLOT in the neoadjuvant setting, and 99% of the patients received placebo and FLOT in the neoadjuvant setting in the placebo arm. Surgery was attempted in 91% of the patients who were enrolled in the durvalumab arm and 90% of the patients in the placebo arm. R0 resection was done in 92% of the patients who underwent surgery and 92% again in the placebo arm. Baseline characteristics were more or less well matched between the two arms. PD-L1 expression was less than 1% in only 10% of the patients and more than equal to 1% in 90% of the patients. So majority of the patients were having PD-L1 positivity. Histologically, intestinal type was around 50%, diffuse around 25%, and unspecified adenocarcinoma another 21%. MSI status: MSI high was in 5% of the patient in both the arm, not MSI high in 64 and 65% in durva and placebo arm respectively, and not evaluable or missing MSI data was there in 31% in durva and 30% in the placebo arm. Coming to the primary endpoint of event-free survival, the median EFS was not reached in the durvalumab plus FLOT arm, and it was 32.8 months in placebo along with FLOT arm, and it was statistically significant. At the end of 2 years, the EFS was 67% for durvalumab arm and it was 59% for placebo arm. In almost all the subgroup, durvalumab plus FLOT did better as compared to the placebo along with FLOT in the perioperative setting. Key secondary endpoint: overall survival data. The median OS was not reached in the durvalumab arm, and it was 47.2 months in the placebo arm, and the 2-year OS was 76% in the durvalumab arm and 70% in placebo along with FLOT arm. Pathological CR, which is a statistically significant improvement, was seen with addition of durvalumab to FLOT. It was 19% in the durva arm along with FLOT and only 7% in the placebo along with FLOT. So the difference was 12%, which is a huge difference if we talk about the perioperative or the neoadjuvant setting, and they have given only 2 cycles of FLOT along with durvalumab or placebo. Secondary endpoint of disease-free survival: the median DFS was not reached in the durvalumab arm and it was 39.8 months in the placebo, and the 2-year DFS was 75% versus 66% in favor of durvalumab along with FLOT arm. Treatment delivery, median number of neoadjuvant cycles was 2 in all the groups, and the number of neoadjuvant cycles of durvalumab or placebo plus FLOT, it was almost 100% in all the groups. Safety wise, adverse events were aligned with the known profiles of durvalumab and the FLOT regimen, and it was not much of a difference between the durvalumab FLOT along with versus placebo plus FLOT. There was a balance between the cohort aligned with the known profiles of durvalumab and the FLOT. The common side effects of any grade were diarrhea, nausea, neutropenia, alopecia, decreased appetite, fatigue, vomiting, anemia, neutrophil counts decreased, peripheral sensory neuropathy, asthenia, pyrexia, and abdominal pain. Conclusion of this study was that durvalumab with FLOT significantly improved the event-free survival versus FLOT alone in resectable gastric and GE junction adenocarcinoma. Event-free survival benefit was consistent across subgroups and geographic regions. There were no new safety concern identified, and overall survival data are encouraging. The final OS data is still pending. Matterhorn supports global adoption of perioperative durvalumab with FLOT as a new standard of care for patients with localized gastric and GE junction adenocarcinoma. Coming to the third important update, which was presented at ASCO GI Cancer Symposium, and this is the Breakwater trial, and it was the analysis of first line in encorafenib plus cetuximab plus chemotherapy in BRAF V600E mutant metastatic colorectal cancer. So this was the first line use of anti-BRAF agents. Key takeaway points from this trial was Breakwater showed statistically significant and clinically meaningful benefit in overall response rate by blinded independent committee review with EC, that is encorafenib along with cetuximab, along with modified FOLFOX6 in the first line setting of patients having BRAF mutant metastatic colorectal cancer. So BRAF V600E mutation occurs in around 8 to 12% of metastatic colorectal cancer, and encorafenib is highly selective ATP competitive small molecule BRAF inhibitor with anti-proliferative and apoptotic activity in tumor cells expressing BRAF 600E and has prolonged pharmacodynamic activity compared with other approved BRAF inhibitors. Preclinical data have demonstrated the combinatorial benefit of encorafenib, cetuximab, and cytotoxic chemotherapy. Encorafenib plus cetuximab is approved for BRAF V600E mutant mCRC in second line and later line settings based on the results of BACON study. First line chemotherapies with or without biologic agents have had limited activity or efficacy for BRAF mutant mCRC. So Breakwater study is an open label multi-center phase 3 study in the first line setting of BRAF V600E mutant mCRC. Patients with age more than equal to 16 years without any prior systemic treatment for metastatic disease and having BRAF V600E mutant mCRC by local or central laboratory testing were enrolled in the study. Patients were randomized 1:1 fashion. There were 3 arms of encorafenib plus cetuximab. Second arm encorafenib cetuximab along with the modified FOLFOX6, and third arm was the standard of care chemotherapy. Dual primary endpoints were progression-free survival and overall response rate by blinded independent committee review, and the key secondary endpoint was the overall survival. Only the primary analysis of overall response rate by BICR at the interim analysis of overall survival and safety in the second arm, that was EC plus modified FOLFOX6, and the third arm, that is standard of care arm, were presented here. So this is the statistical analysis design and summary of disposition. The baseline characteristics were more or less well matched between the EC-M FOLFOX and the standard of care, with 37.7% of the patients having a left-sided tumor in the EC arm, and it was 40.3% being the left-sided tumor in the standard of care arm. Coming to the overall response rate, here you can see 60.9% of the patients had response, and in the EC plus FOLFOX arm, and it was 40% for those who were enrolled in the standard of care arm. Complete response was seen in 3 patients in EC plus modified FOLFOX6 arm and 2 patients in the standard of care arm. Patients with a duration of response or more than equal to 6 months was 68.7% in the EC arm, and it was 34.1% in the standard of care arm. Subgroup analysis wise, all the subgroup favored combination EC plus modified FOLFOX6 against the standard of care arm. The interim overall survival data at the end of 1 year, the OS was 79.5% for EC plus modified FOLFOX6, and it was 66.1% for those who were enrolled in the standard of care arm. Safety wise, there was no new safety signals for EC plus modified FOLFOX6, and the most frequent all causality treatment emergent adverse events were nausea, anemia, diarrhea, decreased appetite, vomiting, decrease in the neutrophil counts, asthenia, pyrexia, and rashes. Dose modification due to adverse events were done in patients with both EC plus modified FOLFOX6 and standard of care. If we talk about the discontinuation rate, for encorafenib it was 11.7%, and for cetuximab it was 13%. Dose reduction of encorafenib was done in 22% of the patients. For cetuximab it was 6%, and dose interruption again in 56.7% of the patients. For cetuximab it was 58.4% of the patients. Conclusion of this study was that Breakwater showed a statistically significant and clinically meaningful benefit in overall response rate by BICR, and this is the one of the dual primary endpoint with EC plus modified FOLFOX6 versus standard of care that was rapid and durable. Data showed a trend for overall survival improvement with encorafenib and cetuximab along with modified FOLFOX6 versus standard of care. Follow-up is ongoing with planned additional interim and final analysis. EC plus modified FOLFOX6 was generally tolerable. There was no substantial increase in the chemotherapy dose reduction or discontinuation due to adverse events compared with the standard of care arm. The most frequently reported treatment emergent adverse events were consistent with those expected for each of the study drugs. Pre-specified analysis of mature PFS and OS data are planned. The Breakwater study supports the use of EC plus mFOLFOX6 as new first-line standard of care for patients with BRAF V600E mutant mCRC. These results also form the basis for the accelerated approval by the FDA of EC plus mFOLFOX6 for the treatment of patients with BRAF V600E mutant mCRC, including in the first line setting. So with this, I would like to conclude my talk. Thank you so much. Thank you, Gunjesh, for this opportunity. Back to the organizers.
Thank you so much for this excellent presentation. Now moving forward, I would like to invite Dr. Avinash Upadhyay. He is consultant medical oncologist at Big Apollo Spectra, Patna. He will be speaking on the new biomarkers in GI cancer. Over to you, Dr. Avinash.
Hi, thank you. Good evening, everyone. Thank you, Gunjesh, for giving me an opportunity to discuss this here. I will be. Can I share my slides from here?
Yeah, you can share it from your session.
Okay. So I will be discussing about the non-invasive biomarkers for the early detection of pancreatic cancers. So why this was important? Because we know that the pancreatic cancer is a deadly disease. The 5-year survival rate for metastatic cancer is very, very, very poor actually. And if we can diagnose this cancer earlier, we might improve the survival. Not only in early case, even in like if we detect in early case, definitely survival will be going higher. So what are the facts regarding pancreatic cancer? So pancreatic ductal adenocarcinoma accounts for more than 90% of all pancreatic cancers. The 5-year survival rates are almost 12%. It's the fourth leading cause of cancer-related deaths in the United States, is projected to become second leading cause of cancer-related deaths by 2030. So, less than 20% of pancreatic cancers are resectable. So, whenever the cases of pancreatic cancer we see in OPD, mostly they will be either like unresectable, borderline resectable, a few. Otherwise, the early cases which are resectable are very less. So, less than 20% only will be upfront resectable. 30% will be borderline resectable, in which we use chemotherapy followed by surgery, and 50 to 60% of the patients will come in a metastatic state only. So the 5-year survival in this pancreatic ductal adenocarcinoma, it is mostly stage dependent. So resectable will have a good outcome, almost 37 to 40% 5 years survival, and metastatic you see only 3%. So out of all pancreatic cancer, we are able to say only 20 to 30% patient for a longer duration of time. Otherwise, the patients do not live for 5 years also. So the rate of survival is very less in borderline as well as in metastatic. So we need to improve this. So how we can improve this? By using the window of opportunity for the early detection of the pancreatic cancer. So it has been shown, if you see the pancreatic cancer development to pancreatic cancer progression, it takes almost 15 to 20 years. So 18 to 90% of pancreatic precancerous lesions earlier will be their low grade or intermediate grade. They will take 15 to 20 years to progress from stage 0 to stage 1 to 3 to stage 4. So this window is quite long, and we can use this by using the biomarkers to detect this cancer early during this period of time. So why right now we are not doing? Because there is a lack of availability of robust diagnostic biomarkers. So what are the biomarkers? Rightly we have, actually we do have only this carbohydrate antigen 19.9, which is expressed and studied in number of pancreatic and hepatobiliary disease as well as other malignancies, and that might be false positive. The common mimickers of the disease are focal chronic pancreatitis, autoimmune pancreatitis, solid pseudopapillary neoplasm. So we cannot distinguish these conditions from pancreatic carcinoma cancer. Screening test, there is no availability of a screening test which is a cheap, easy, and accurate screening test. The imaging modalities CT, MRI, US, and PET scan, they also have a limitation. So they can detect only tumor which are more than at least 0.5 centimeters. So the sensitivity of these imaging tests also comes into picture only when there is a development. So we need to take this pancreatic adenocarcinoma before it is evident much on these scans. So, what is the future? So, the future for cancer detection is liquid biopsy biomarkers. So, what is these? So, if every tumor, they have certain this tumor DNA or tumor exosomes which is secreted into blood that can be detected through doing liquid biopsy. So, in liquid biopsy, we do get cancer cells. We can go for tumor DNA, we can go for cell-free DNA, we can go for tumor exomes. So detection of various kind of tumor cells we can identify by just doing a blood test, which can tell us the development of pancreatic cancer before itself. So the current landscape of early detection tests in pancreatic cancer, we have serum CE and CA19.9. There are other tests also, but I think these two biomarkers are important. Then now this is Avantect, which is a modified cell-free DNA sequencing. So cell-free DNA mutations and proteins we can detect by doing through this liquid biopsy that can tell us beforehand if any pancreatic cancer is going to develop or not. So blood-based detection for pancreatic carcinoma remains suboptimal. tumors. So CA19-9 only 3% patients will have the higher value. CEA. So one test, it is, there are various tests, but the sensitivity varies and the specificity for the early detection of pancreatic cancer. So could microRNAs be an answer for development cancer markers? So these are expressed frequently altered in cancers. They are highly stable and abundantly expressed. It's easily detectable in body fluids. In blood, exists primarily in two forms. There are cell-free microRNAs or exosomal microRNAs. So most published data is on cell-free microRNAs, which are highly sensitive but lack cancer specificity. So these are cancer-free microRNAs and exosomal microRNAs. So these can be detected. So could microRNA be an answer for developing cancer markers? So expression frequently altered in cancer, but highly stable and abundantly expressed, easily detectable in body fluids. So a combination of cell-free and exosomal microRNA biomarkers may offer a superior diagnostic approach because cell-free is highly sensitive and the exosomal microRNA become specific. So if they become highly sensitive and specific, so if you diagnose both, if you detect both, it will be easy to get a superior diagnostic approach for this condition. So there was a study which was published. It's a multi-center cohort study based on exosome-based transcriptomic signatures for non-invasive early detection of patients with pancreatic ductal adenocarcinoma. So this was this was the study in which they have tried to read the exosomal microRNAs as well as the cell-free microRNAs. So candidate for this cell-free and exosomal microRNAs were overexpressed in pancreatic ductal adenocarcinomas. You can see the values here. So the different microRNAs have been seen in the patients who are having this pancreatic ductal adenocarcinoma. Exosomal microRNAs as well as cell-free RNAs. So these two collectively can give a better test, which is better sensitive and is more specific. So the cell-free and exosomal microRNAs combination panel was superior versus individual biomarker panels in PDAC. So this is the cell-free microRNA panel. AUC was 0.84. This, or if you use this exosomal microRNAs, the AUC was 0.89. But when you combined the stacked, the AUC goes up to 0.93. So if we use both the cell-free microRNAs as well as exosomal microRNAs panel, we stack together, the AUC goes 0.93. So the sensitivity as well as the specificity increases if we combine the two tests. So combination of C19.9 level together with the exosome-based liquid biopsy signature improves the accuracy for PDAC diagnosis. So microRNA signature plus CA19, you see the area under curve goes up to 0.99. So most of the patients who are going to develop pancreatic ductal adenocarcinoma, if they have higher value of CA19.9 and we have done the microRNA signature, I think more or less we are going to detect that case very early. Or only CA19.9 AUC was only 0.88. So combining these two, not only in stage 1 to 2, stage 1 to 4 also. So stage 1 to 4 it was 0.99, even in stage 1 to 2 it is 0.99. So combining this microRNA signature with CA19.9 actually yields a very sensitive and very specific test for the diagnosis of this condition. So what is the current state of our assay? So there is a study, Panzion study, so pancreatic cancer exosomal early stage detection. So this study built on previous results and validate our biomarkers in a large prospective multi-center cohort. It's a machine learning based approach for data analysis and assay development. So what were the patient cohort actually taken? So it was taken from various countries like US, Japan, China, and South Korea. So out of this pancreatic ductal adenocarcinomas were almost 613 and non-disease controls were taken 594. Total 1207 patients were assessed. So patients with PDAC had ductal adenocarcinoma had higher Panxion scores across all. Sorry. So you can see the patients who are having this pancreatic ductal adenocarcinomas, they had higher values of the Panxion score. So if we calculate this scoring system, and if you see this correlates with the development of pancreatic ductal adenocarcinoma. So early stage PDSA detection, 3 independent cohorts. So if you see the stage 1 to 2, AUC goes up to 98.4% in training cohort. In validation cohort, it was 97.3%, and in testing cohort, it was 95%. So more or less, the sensitivity and specificity remains high for this score if we calculate based on the miRNA's profile. So high performance of Panxion score was seen even in CA19 point non-secretors. So this is important. Most of the 30% of the patient might have normal CA19.9 value. You can see this. The Panxion scores were better even if the patient who is not having CA19.9 high value, and the area under curve goes up to 91%. So combining Panxion score with CA19.9 further improves. So if the patient who is having or secreting this CA19.9, if you combine this score, the sensitivity and specificity further increases. It almost goes to 96.6% the area under curve, compared to when you use CA19.9 point alone, which is 81%, and Panxion score alone was 95%. So combining both the two actually increases the sensitivity as well as the specificity of the test. So Panxion blood-based test is highly pancreatic ductal adenocarcinoma specific, and almost 84.3% sensitivity was there, and 94.5% specificity was there for pancreatic ductal adenocarcinomas. So this score drops after surgery, but surge pre-recurrence. So when surgery was done for such and such these patients who were having pancreatic ductal adenocarcinoma, and when this score was repeated, this actually decreases, and that is quite understood. And there a surge also was seen pre-recurrence. So this means that this score well correlates with the development of tumor inside the body. So this Panxion score tracks with the disease during treatment. So neoadjuvant, it goes down. For post-surgical follow-up, the patient, if it is recurring, the score goes high. So PDSA early detection blood test performance was done in almost 1207 patients, and sensitivity and specificity almost remained 90% in USA. In China and South Korea also, it was more or less 80 to 90%. This blood test could robustly detect the early stage pancreatic cancer. Stage 1 to 2, it's almost 91%, and stage 3 to 4, it is 93%. Further improvement, if you combine with CA19.9, it goes to 97% in stage 1 and 2, and 3, 4, it goes to 97%. So if we summarize, the microRNA-based liquid biopsy assays for the early detection of pancreatic cancers are promising and is ready for the large-scale validation studies. A combination of cell-free and tumor-derived exosomal markers, they offer superior diagnostic accuracy. Some of these assays have been licensed or are currently being negotiated to undertake prospective clinical trials for further evaluate diagnostic performance. So, as this is a very, very aggressive tumor, development of such biomarkers will definitely improve the survival in such conditions. So, thank you from my side. Thank you.
Thank you so much, Dr. Avinash, for your insightful talk. Now, let's moving forward. I would like to invite on dice to Dr. Chandrasekhar. He is considered medical oncologist at HCG Ranchi. He will be speaking on the management of colorectal cancer. Over to you, Dr. Chandrasekhar.
Yeah, good evening. Is my screen visible?
Yeah, sir, it is. Just make it full screen, sir.
Yeah.
Yeah, now it's okay. Yeah, thank you.
Hi, thank you. Good evening, everyone. I would like to thank Gunjesh and organizers for the opportunity. I'll be talking on metastatic colorectal cancer management. What are the recent updates we have? So colorectal cancer is one of the common cancers what we see in our clinical practice, and it is a common cause of death among cancer patients. If you talk about males, then it is third most common cancer globally. And similarly, in females, it is third most common cancer after breast and lung globally. So colon cancer patient can come to us with different stages. It can be a resectable disease. It can be a potentially resectable disease, or it can be an unresectable metastatic disease. So coming to whether metastatectomy has improved survival of colon cancer patients, yes, the answer is yes. So 5-year overall survival has improved up to the tune of 30 to 35% with metastatictomy as compared to only 20% with chemotherapy. So liver resection versus no resection. Yes, liver resection has improved survival. Curative liver surgery versus no curative surgery. Curative surgery has improved survival of metastatic colorectal cancer patients. What are the other options we have for liver metastasis? We can have hepatic artery infusion of chemotherapy. We can have SBRT. We can have consolidation arterial radioembolization. So these are local therapies which can be used for limited liver metastatic disease. So coming to this potentially resectable disease, so there are several trials done in the past with chemotherapeutic agents, with biologicals plus chemotherapy, and with triplet chemotherapy versus doublet chemotherapy along with targeted therapy. So we have data for FOLFOX or FOLFIRI with cetuximab. This trial Selim was done in China, and it has strongest evidence. Up to 60% of limited metastatic disease or potentially metastatic disease can be converted into a resectable disease, and patients had improved survival. Coming to triplet versus doublet with bevacizumab, yes, triplet chemotherapy has advantage if your patient is fit enough and limited comorbid conditions. Then triplet chemotherapy should be used if disease is potentially resectable. So coming to what are the chances of getting it converted into potentially resectable, we call it conversion therapy. So there are several trials and meta-analysis of all these trials so that around 25.7% of patients can be converted into resectable disease with the use of chemotherapy plus EGFR inhibitors. So whether biologicals should be used in the perioperative setting or not. So biologicals can be used if your disease is resectable, and you can take out limited liver metastatic disease. Then biologicals can be combined with chemotherapy, and it has shown strong conversion ratio. Now coming to disease where you cannot resect liver metastasis, that is unresectable metastatic disease. So there are several biomarkers based on which we decide our first line therapy. Nowadays we have strong data plus for IO plus IO combination in those patients who are MSI high, and there are several other agnostic as well as tumor biomarkers based on which we can decide our first line and subsequent lines of therapy. So immune checkpoint inhibitors as first line standard of care for MSI high metastatic colorectal cancer patients. We have data for Nivo plus EP combination versus chemotherapy, and it has strong data. Hazard ratio is only 0.21. If you talk about the median progression-free survival, then with only chemotherapy it is 5.9 months in MSI high patients versus not reached in IO combination. Objective response rate is also much better in immuno plus immuno combination arm. It is 55% versus 31%, and median PFS2 is also improved with IO combination as compared to only chemotherapy. Similar to this, we have data for pembrolizumab as well. Pembro versus chemotherapy. Objective response rate is 45% versus 33%. And median duration of response is not reached versus 10.6 months. Median OS is not reached in immunotherapy arm versus 36.7 months in only chemotherapy arm. So if you see the curves of Nivo EP versus chemotherapy, then you have a PFS of I think more than 54 months. So this is very strong data in metastatic setting. Coming to whether to go for triplet chemotherapy or doublet chemotherapy as first line treatment in metastatic colorectal cancer patients. So yes, if your patient is fit with limited comorbidities, potentially able to tolerate the toxicities of triplet chemotherapy, then we can have triplet chemotherapy, particularly in those patients who have high risk disease. like right-sided tumor, BRAF mutated tumor, so HER2 positive tumors. So these subset of patients benefited more with triplet chemotherapy as compared to doublet chemotherapy, and it can be used. Now, this trial, TRIBE2 trial, where unresectable metastatic colorectal cancer patients were randomized into FOLFOX plus bevacizumab for 8 cycles, and then 5-FU plus bev was given as a maintenance therapy. And upon progression, it was switched to FOLFIRI plus bevacizumab for 8 cycles, and then 5-FU plus bev as maintenance. Experimental arm was FOLFIRI plus FOLFOXIRI plus bevacizumab, that is triplet therapy with bevacizumab for 8 cycles, and this was followed by 5-FU bev as maintenance therapy. And upon progression, it was re-challenged with triplet therapy with bevacizumab for 8 cycles, and then 5-FU bev maintenance. Primary endpoint of this trial was PFS2. So if you see the data of experimental versus control arm, then second line PFS was 6.2 versus 5.6 month with a hazard ratio of 0.87, and second line response rate was 19% versus 12%. So FOLFIRINOX with bevacizumab, patients had better response rate as well as better PFS2 as compared to FOLFOX or FOLFIRI plus bevacizumab. So this is the classical teaching, right-sided versus left-sided. What should be the first line? We know right-sided colon cancers are relatively resistant to EGFR inhibitors, and even if they are RAS wild type, and we don't use EGFR inhibitors as first-line therapy in right-sided colon cancer as first-line treatment. So in those patients who had left-sided metastatic colorectal cancer, overall survival was improved in those patients who received EGFR inhibitors and had RAS wild type. Median overall survival was 37.9 months in panitumumab or EGFR inhibitor arm versus 34.3 months in bevacizumab plus chemotherapy. Now we have data from Paradigm trial as well, which have shown that EGFR inhibitor is better as compared to VEGF inhibitor as first line RAS wild type left-sided metastatic colorectal cancer. Coming to PFS data, median PFS was 13.1 month in panitumumab arm versus 11.9 in bevacizumab arm. If you talk about the data of right-sided tumors, then EGFR inhibitor with FOLFOX, median overall survival was 20.2 months versus 23.2 months in bevacizumab arm. So in fact, it was inferior to anti-VEGF treatment in right-sided metastatic colorectal cancers. Similarly, median PFS was also less in panitumumab arm as compared to bevacizumab arm. And now there is concept of negative hyperselection. So what is this negative hyperselection? Most of the times we talk about only RAS mutation, whether it is wild type or mutated. But there are several other mutations or biomarkers based on which we can say that this tumor biology is bad and this cancer is relatively resistant. So what are those mutations? Those are BRAF V600E. It can be a HER2. It can be, there are several different fusions as well in the form of HENTRAC, RAT. So these fusions are associated with relatively resistant disease. And that's why the concept of negative hyperselection, where we choose patients in whom these mutations or these gene fusions were excluded. So if you talk about the median OS data of such patients, then negatively hyperselected patients, they had higher median overall survival as compared to all comers. It was 42.1 months in negatively hyperselected population versus 24.2 months in those patients where there was gene alteration. So it showed that EGFR inhibitors work better where these mutations or gene fusions were absent. If you see the data of negatively hyper-selected subpopulation in right-sided tumors as well, then also there was benefit of giving EGFR inhibitors if the patients were negatively hyper-selected. Means if you exclude these mutations or these fusions or these resistant pathways, then EGFR can act in right-sided tumors as well. So median OS was 38.9 months in negatively hyper-selected population versus 14.1 month in gene-altered population. And in bevacizumab, it was 30.9 months in negatively hyper-selected versus 18.5 month in gene-altered population. So if this subset can be benefited with EGFR inhibitors, but in our clinical practice, we routinely don't do it. And most of the time in right-sided tumor, we don't use EGFR inhibitors. Coming to second line therapy for metastatic colorectal cancers, we have several biomarkers and it can drive treatment decisions. So as we all know, commonest mutation we see is TP53, but that does not have any therapeutic significance, although it is associated with resistance and bad tumor biology. Therapeutic significance we have is KRAS. Most common is G12D or G12V, and it has the highest frequency of mutation. Apart from this, we have BRAF, we have HER2, we have NTRK, and there are several fusion gene as well. So KRAS G12C mutation directed therapy in metastatic colorectal cancer. So classical teaching is you don't have to give EGFR inhibitors in KRAS mutated tumors, but this subset is an exception. This is the only subset G12C where it can be given with KRAS inhibitors in the form of sotorasib or agarasib. So EGFR inhibitors can be used in this subset of KRAS mutation, and they had shown improved survival and improved objective response rate in later lines of therapy. We have data for BRAF V600E directed therapy in metastatic colorectal cancers as well, and encorafenib with cetuximab can be given as a later line of therapy. And now we have data for encorafenib with cetuximab with chemotherapy in those patients who have BRAF mutated but KRAS wild type. So it can be combined with chemotherapy, or encorafenib can be given with cetuximab as a later line of therapy. HER2-directed therapy in metastatic colorectal cancer. So we have several agents. We have tucatinib, we have trastuzumab. It can be combined, and objective response rate is 38%. Duration of response is 12.4 months, and overall survival is 24 months. We have combination of lapatinib and trastuzumab, and it has improved overall survival as well as progression-free survival as later line of therapy. Trastuzumab can be given with pertuzumab with an overall response rate of 32% and overall survival of 11.6 months. We have data for TDXT as well, although it is phase 2 data. But it can be given after later lines as a later line of therapy after chemotherapy and biologicals or anti-VEGF has been used as a previous line of therapy. Now these are other biomarkers which can be targeted. NTRK fusions, these are oncogenic driver in multiple solid tumors in adults and pediatric age group as well. So NTRK gene fusion frequency in colorectal cancer is very low. It is less than 1%. In fact, it is nearly 0.3%. But it can be targeted once you get it. It can be targeted with different TKIs we have as a later line of therapy. Similar to NTRK, we have RET fusion, and it can be targeted with TKI. It has an overall response rate of nearly 44% and duration of response of nearly 25 months. This seems to be promising data, and we have data for this agent in other cancers as well. Similar to colon, we have lung cancer, pancreatic cancer, and different other solid tumors where it can be used. Coming to third line of therapy, we have data for trifluridine tipiracil plus bevacizumab. It can be used once you have used FOLFOX or FOLFIRI, means oxaliplatin or irinotecan based chemotherapy. It can be combined with bevacizumab as a third line of therapy in those patients where MSI is stable. So we have data from Sunlight trial, and median OS with combination is 10.8 months versus 7.5 months with only trifluridine and tipiracil, and hazard ratio is 0.61. When we talk about the PFS data, then median PFS is 5.6 months versus 2.4 months with only trifluridine and tipiracil. So combining bevacizumab has shown promising data. Now this is a selective VEGF 1-3 inhibitor, frequentinib, and it can be used as third line of therapy. We have data from FRESCO trial where it has shown median PFS of 3.7 months versus 1.8 months with chemotherapy. And although the response rate is not that great, but it has improved survival in patients when used as a later line of therapy. We have regorafenib. We are using in our clinical practice, but as we all know, this is very poorly tolerated drug, and most of the patients do not tolerate full dose. Most of the times we have to reduce the doses, but it has shown response in later line of therapy, and it has shown improved survival of metastatic colorectal cancer patients. So what are the imaging therapies in MSI, non-MSI high metastatic colorectal cancer? We have options of liver transplantation in liver-only metastatic colorectal cancer, but this has very stringent inclusion criteria. This has very selective population where it can be used. So in highly selected patients with unresectable liver-only metastasis, liver transplantation plus chemotherapy has improved survival as compared to only chemotherapy. So if you see the data, then 5-year overall survival for liver transplantation plus chemotherapy versus chemotherapy is 56.6% versus 12.6% with a hazard ratio of 0.37. But this has to be very strict, and very limited number of patients are eligible for liver transplantation. Now coming to this immunotherapy, we have novel immunotherapy, botensilimab and balstilimab in non-liver metastatic colorectal cancer patients. So objective response rate, overall response rate in all evaluable patients was 17%. And in those patients who had no liver metastasis, overall response rate was nearly 23%. Median PFS was 4.1 month, and median overall survival was 21 months. Coming to regorafenib plus nivo-ipi in MSS patient, overall response rate is 27.6%, and median overall survival is nearly 20 months. So botensilimab is a novel immunotherapy agent. It can work in cold tumors, that is where you don't have that much lymphocytic infiltrates, and when your disease is refractory to other immune checkpoint inhibitors, it can be tried, but we don't have mature data for this agent as of now. Then there are several other novel agents or emerging therapies which are coming for MSS patients. It can be used to target KRAS mutations. There are several KRAS inhibitors in development, and it can come as later line of therapy for metastatic colorectal cancer patients. So coming to my last slide, what is the optimal treatment of non-MSI high metastatic colorectal cancer patients? So if your patient have left-sided disease, KRAS wild type, RAF negative, and negatively hyperselected via circulating tumor DNA analysis, then we have FOLFOX or CAPOX or irinotecan based chemotherapy backbone, doublet chemotherapy with anti-EGFR, and upon progression, we can switch to either oxaliplatin or irinotecan-based doublet chemotherapy with bevacizumab. If your patient has MSI high, then obviously immune IO combination, Nivo-IP combination has strongest data as of now as first line therapy. And if your patient have MSI stable, RAS-RAF mutated, then obviously you can use triplet chemotherapy if they can tolerate the toxicity, or we can have option of biomarker-driven therapy in the form of HER2 inhibitors, BRAF inhibitors, and TRK/RAT, these inhibitors. So key learning point where MMR deficient is the first biomarker to receive a tissue agnostic approval for anti-cancer therapy. Biomarker-driven therapy is rapidly evolving in metastatic colorectal cancer management, similar to lung cancer. And in trials, non-MSI high colorectal cancer patients with non-liver metastasis appear to derive benefit from immunotherapy. The combination of these novel two immune checkpoint inhibitors in the form of botensilimab and balstilimab recently demonstrated encouraging clinical activity with durable responses and manageable toxicity in MSI stable metastatic colorectal cancer patients who don't have any active liver metastasis. With this, I would like to stop. I would like to thank organizers for the opportunity. Thank you.
Thank you so much, sir, for your excellent talk. Now let's roll over the dice. We'll start with the GU cancer session. And for the first talk, I would like to invite Dr. Satwik Khaddar. He's consultant medical oncologist at Apollo Hospital, Indore. He will be speaking on the ESCO Outlook 2025 on GU cancers. Over to you, Dr. Satwik.
Yeah, thank you. Can you share my slides?
Yeah, I'll just share it from my side. The slides are visible.
Yeah. So good evening, everyone, and thank you for to the organizers. So I'll be very quick because there are many abstracts which were discussed in ESCO GU this year, and I'll be just highlighting the results. So this is the first one, gene signature predictor of dose response to prostate radiation. Basically, validation of PORTOS in phase 3. Sorry, next slide. Validation of PORTOS in phase 3 trials. Next slide. So basically, PORTOS is prostate cancer radiation therapy outcome score, and it predicts salvage dose response in various trials. It predicts definitive dose response, and it is associated with hypoxia and immune response. It can help guide radiation dose escalation, de-escalation, and studies which are investigating PORTOS and ENI toxicity, ADT, etc. are ongoing. Toxicity is being studied in RTOG 0126 trial. Next. So this is the next presentation where radical prostatectomy versus radiotherapy was studied in high-risk prostate cancer, and this is the individual patient data from 2 phase 3 randomized trials. Next. So key takeaway points from the individual data analysis of these two trials is that the current NCCN guidelines recommended treatment regimens, a radiotherapy-based treatment, appears to result in a lower incidence of distant metastasis than a surgery-based regimen for patients enrolled on these phase 3 trials. Approximately 80% of the men with high-risk prostate cancer treated with surgery will receive further treatment or experience recurrence, and adjuvant or early salvage RT remains critical in this population. And use of triplet or quadruplet therapy of neoadjuvant chemo ADT, radical prostatectomy, and personalized post-op RT or ADT may mitigate these differences when compared to doublet therapy. And there is one trial called SPCG15, which is actively enrolling, and it aims to directly address this question. Next. This is the next study where safety and efficacy of durvalumab in combination with neoadjuvant chemo, that is GemCis or GemCarbo, in patients with operable high-risk upper tract urothelial carcinoma was studied. Next. So this was a phase 2 study. It was in upper urinary tract cancers, and the combination was reported to be safe and did not negatively impact surgery. And encouraging results were seen in terms of residual disease, mainly when cisplatin-based chemotherapy is used. And obviously, this study will be followed by a phase 3 study comparing chemotherapy alone versus chemo plus immunotherapy, which is an INDUCT 3 study. Next. Now coming on to high dose chemotherapy in testicular cancer. Next. So high dose chemotherapy is effective salvage therapy for patients with relapsed germ cell tumor, and cures can be achieved in patients with platinum refractory disease, mediastinal non-seminoma, third line and beyond, and progressive brain mets. Basically, these all are poor prognostic conditions, and our optimal patient selection for high dose chemotherapy versus standard dose is currently being studied in a phase 3 trial. Next. Now, which patients with metastatic HSPC benefit more from androgen receptor pathway inhibitors? This is a stopgap meta-analysis of individual patient participant data. Next. So this study carried out under YODA project used data obtained from Yale University, and the interpretation and reporting of research using this data was done. Next. RPLND for patients with stage 2 seminoma, management strategies and current controversies. Next. So open nerve sparing RPLND was reported to be oncologically highly effective in low volume stage 2A/B marker negative pure seminomas, and it was also associated with minimal surgery associated morbidity, and it reported 100% cure for 10 to 30% of the relapsing patients on salvage. Avoidance of long-term toxicity due to standard treatment with 3 cycles of BEP or retroperitoneal RT. Next. So these are the results from Cosmic 313 trial where they combined cabozantinib with nivo-AP in previously untreated advanced renal cell carcinoma. So first line treatment of RCC with a triplet regimen of nivo-AP with cabo. Next. So after 45 months of follow-up, first line treatment with a triplet continued to demonstrate a PFS benefit over placebo plus nivo-AP. There was no significant difference in OS in the two arms. So OS was similar, and but the toxicities were higher in the triplet arm. Uh, and there are some exploratory immune cell results which investigators are looking into as a post hoc analysis. But as of today, this triplet combination is not recommended because higher toxicity and similar OS as compared to doublet nivo-AP. Next. So this is the final follow-up results of Checkmate 9ER where nivo plus cabo was tried versus sunitinib in first-line RCC. Next. So the long-term efficacy benefit was observed with nivo cabo over sunitinib with a median of 67 months of follow-up. And the safety and tolerability with long-term follow-up were manageable and consistent with the previous results. And these results continue to support nivo cabo as a standard of care for first-line advanced RCC. Next. So these are the results of Checkmate 274 where adjuvant nivo was compared with placebo for high-risk muscle-invasive urothelial carcinoma. Next. So as per this extended follow-up, adjuvant nivo continues to show DFS benefit versus placebo in patients with muscle-invasive bladder cancer, and OS data favored adjuvant nivo over placebo, and there were no new safety signals, and these results support the use of adjuvant nivolumab in muscle-invasive bladder cancer, and now subcutaneous nivo has also shown to provide equal clinical benefit as compared to standard IV. So we can also use subcutaneous nivolumab in these patients. Next. These are the additional efficacy and safety outcomes from and the impact of pathological complete response in the Niagara trial. Next. So Niagara trial demonstrated statistically significant clinically meaningful improvement in the event-free survival and overall survival with a 10% improvement in the PATH-CR rate. So what they did was they compared durvalumab plus Gemcis versus Gemcis in patients with bladder cancer, and the durvalumab perioperative durvalumab arm had a higher EFS and overall survival and a higher PET CR as in both PET CR as well as non-PET CR group. Next. Which so I think this is again repeated. Next. Next. This is the Keymaker U03 study where pembrolizumab and target therapy combinations for advanced clear cell RCC were studied. Next. As per this study, majority of the patients received 2 or more prior lines of therapy, and lenvatinib plus belzutifan showed a numerically higher overall response rate with a median PFS of 12.5 months. Results from pembro plus belzutifan were similar to those observed with belzutifan monotherapy, and pembro plus lenva also showed higher anti-tumor activity in these patients. Adverse events were generally manageable and no new safety signals were reported. Next. Understanding radioligand therapies for advanced prostate cancer. Next. So lutetium PSMA radioligands are a promising new class of treatment. The synergistic effects of combined lutetium therapy with other agents could offer new avenues for enhanced treatment efficacy. And there is continued research on predictors of response and mechanisms of resistance, which will inform rational combinations in future. Next. Impact of salvage therapies and functional outcomes and quality of life. Next. So as per the study, patient-reported QOL in existing trials suggests that systemic therapy has mild to moderate impact, but it is possible that we may not be measuring what matters. Trials that reduce exposure or avoid castration may eventually provide an opportunity to maximize QOL and maintain disease control. Next. Thank you.
Thank you so much, Dr. Satwik, for your quick presentation. Uh, Next, I would like to invite Dr. Amit Kumar. He is Associate Director, Medical and Hemato-Oncologist at Jayaprabha Medanta Super Specialty Hospital, Patna. He will be speaking on management of MUC. Over to you, Dr. Amit.
Dhruv, just give 2 minutes. Doctor is joining.
Okay.
Dr. Amit has joined. Hello.
Yeah, hello.
Hello. Good evening, Dr. Amit.
Yeah.
Yeah. So I'll introduce now Dr. Amit Kumar. He is Associate Director at Medical and Hematologist at Jayaprabha Medanta Super Hospital at Patna. He will be speaking on management of MUC. Over to you, Dr. Amit.
So yeah, good evening, everyone. So the topic assigned to me is about the management of metastatic urothelial carcinoma. So what are the new things which are coming in the picture? So as we see, the initial 1980s when cisplatin was the most active chemotherapy. Thereafter, the combo come in when cisplatin has been combined with gemcitabine or then that type of protocols has come. And then again, after 25 years of the course, the next molecule that is pembrolizumab has come in picture. Thereafter, maintenance avelumab after induction platinum-based chemotherapy has been introduced in 2020, and thereafter CheckMate study which shows Gemcis Nivo, and now the recent advancement is the EV plus pembro in this arm. So if we go with the Javelin Bladder 100 study, which is a phase 3 randomized open-label study of unresectable locally advanced metastatic urothelial carcinoma, in which Gemcis or Gemcarbo has been studied in combination with has been given initially, and thereafter avelumab as a maintenance therapy in these patients. And what we see the median OS measured from the start of chemotherapy. So 13 months of median OS benefit with avelumab maintenance from start of the first line chemotherapy is seen. So there's a 9.2 months improvement in the median OS from 20 months to 29.7 months. So does this first line chemotherapy regime actually have an effect? So if, whether you're using Gemcis or Gemcarbo and the patient is having CRPR or stable disease and given either avelumab or best supportive care in these patients, the OS benefit with avelumab, so in this first line, is irrespective of the first line chemotherapy, whether it's a Gemcis or a Gemcarbo. So in the Gemcis arm, it is 31 months, and in the Gemcarbo arm, it is 25.8 months. So that does response to this chemotherapy matters. So what we see that whether there is a CRPR or stable disease, what happens? So either it is a CRPR or stable disease, there is a response being seen in almost all the cases. The rate is 0.72 with CR, with PR 0.7, and with stable disease 0.84. So how long does one like to continue with this avelumab maintenance? So the median PFS of 26.7 months in patients who are exposed to Bavencio maintenance for more than 12 months, and median is not reached. So what we see that the PFS, if the patient has taken at least 12 months of more than of Bavencio, the PFS has gone up to 26 months and the OS has not reached. So if the patient is able to take it for a longer duration, the response is also longer. So what are the other approaches? So apart from the Javelin bladder, which has been discussed, the other is the CheckMate trial, which shows the Gemcis as compared to Gemcis Nivo. And the arm is Gemcis, if we see, is around 18.9 months, the median OS, similar to that in the Javelin, where 20.5 months is the best care group. But when the nivolumab is added, the survival increases to 21.7 months only as compared to 29.7 months with avelumab maintenance, and hence it's not approved in India. The other marked change which has come, the EV302 trial, which has increased the chemotherapy regime from 16 months to 31.5 months. So there's just a doubling. So it's not available still in India. So if we see the Gemcis Nivo versus Gemcis in cisplatin eligible patient, Nivo is given in 360 mg, so 3 weekly cycles as compared to Gemcis, followed by Nivo maintenance for up to 24 months. There's a 9 days PFS benefit and 2.8 months OS benefit only in this arm. So the reanalysis of urothelial cancer chemoimmunotherapy trials with differential censoring, they say that could differential censoring explain the inconsistent results? The phase 3 investigating the addition of PD-1 or PD-L1 inhibitors to platinum-based chemotherapy as first-line treatment in advanced urothelial cancer. So what we see in this comparative effectiveness study of around 2,100 patients, where they included IMvigor 130, Keynote 361, and CheckMate 901. So there is no differential censoring seen, but there was more than 30% excess censoring in the chemotherapy only groups in the Keynote 361 and CheckMate 901 trials. So after sensitivity analysis, the PFS benefit was no longer significant in the keynote or the checkmate, and analysis of the OS similarly shows no differential censoring, but there was more censoring in chemotherapy only groups in the checkmate 901. So what we see that after sensitivity analysis, the OS benefit of adding chemo Nivo to chemo was lost before adjustment only. So views on the available data for I'll say the patient's eligibility for the 3 first-line regime. So Javelin bladder, avelumab first-line maintenance plus BSC versus BSC alone. We see the GemCis for GemCarbo followed by avelumab maintenance. If we see in randomized trials, the 80% of the patients with locally advanced or metastatic urothelial carcinoma achieve disease control with first-line platinum-based chemotherapy, indicating them a high eligibility for avelumab maintenance. So the CheckMate 901 study, which combined GemCis plus Nivo upfront and followed by GemCis in comparison to GemCis, followed by maintenance, and the EV plus Pembro arm, which also has the upfront as compared to GemCis. So 32.2% receive first-line avelumab maintenance following a response to platinum-based chemotherapy in this. So the EVITA is the proposed EV eligibility criteria. So patient meeting at least 2 of the criteria may be deemed unsuitable for EV plus Pembro treatment. So what are these criteria that you cannot give the patient this? So if there is a ECOG performance status more than 2, HbA1c level more than 8%, creat clearance less than 45, any corneal or retinal abnormality, and grade more than 2 sensory or motor neuropathy. So HbA1c can be replaced by baseline glucose of more than 150 milligram per DL in 2 consecutive blood samples 1 week apart. So you have to take care of the renal function, the eye function, the neuropathy, and diabetes. So these are the things one have to be taking the performance status. So if we see what percentage of the patients have the characteristic of the CVTEC criteria and when you want to add or remove. So the patient eligibility we see for Javelin trial, it is around 80%. For CheckMate, it has the cisplatin eligibility is the strong thing, so it is decreased to 50%. And for EVITA trial, it is again around 80% patient would be eligible for this. So do these eligibility percent reflects similar, I'll say the real world evidence suggests. So the data from the RCTs and support patient counseling, there are survival outcomes for avelumab first line maintenance are consistent with these real world studies. So the median PFS is around 5.5. The 12-month OS rate is going to around 71.3%. So the Indian real-world data evidence on avelumab maintenance is also consistent with the RCTs and the global the real-world evidences. The median PFS is around 5 months, and in patients who received avelumab for more than 6 months, the median PFS was 11 months, and the median OS is not reached. The 12-month OS rate is 82.1%. So in the evidence and the EuroCube real-world studies, patients who received first-line platinum-based chemotherapy, avelumab first-line maintenance, and two ADC treatment had a median OS of more than 3 years. So the median OS in the subgroup treated with the second-line ADC treatment, EB, was more than 40 months from the start of therapy. So the evidence study take first-line platinum-based, CRPR avelumab maintenance, and then second-line enfortumab vedotin. As compared to the EuroCure study, which is the median OS after first-line chemotherapy initiation was longer in the avelumab group. So the outcome of with the EV plus Pembro real-world studies, you may see the 12-month PFS is 30 months and the 12 months OS is 67% in the UNITE, whereas in the trial data it shows around 83% as compared to the real world 67%. So the result supports the disease control rate observed in the first line EV plus Pembro trial. The overall response rate and 12-month PFS were comparatively low in these studies as compared to the trials. So what we have evaluation of the global and Indian data. So we'll see the baseline characteristics of the UNITE study, which is alteration in TP53 and KMT2 may be linked to inferior outcomes for patients treated with enfortumab vedotin and pembrolizumab. So that has to think the molecular markers you have to do in all these patients to see whether there is any response or not. And EVP plus Pembro outcomes outside clinical and biomarkers of benefit in patients we see. Treatment with EV plus Pembro outside clinical trials showed robust disease control rate, but a more modest overall response rate compared to the frontline clinical trials. And alteration in the TP53 and KMT2 may be linked to the inferior outcomes with this. So sequencing, subsequent therapy after CheckMate 901, we see only a limited number of patients were on maintenance avelumab in the GEMSIS arm, and a higher percent would have helped to gauge the results better. So after that, avelumab maintenance is only given in the GC arm is only up to the 9% of the patient, and the NEMO you see 1% of the patient. And if we see any immune checkpoint inhibitors, 8% of the patient in the Nivo arm, and 40% of the patients have received the others immunotherapy later on. So more than 74% patients of GEMSIS Cabo arm received subsequent immune checkpoint inhibitors in the JB100 study, and this was first reported in 2020. The CM901 in 2023. So if with lesser immune checkpoint inhibitors being used in the comparator arm, that's the one again the question. So if we see the EV302, the number of EV plus Pembro as compared to chemotherapy. So in this subsequent therapies, if you see the platinum-based therapy is around 25% in this subset as compared to the chemotherapy arm where 3.8%. And the PDL1 inhibitors in this arm is also less, 1.6 as compared to the chemotherapy, 58.6. So limited avelumab maintenance is given in the chemotherapy arm. That is one thing. And what would be the second line treatment options? The patient have initially received EV plus Pembro, so that patient might be only going to receive GEMSIS as the second line. So how to sequence this to optimize the maximal outcome? After CM901, no data, EV302, no data. But for Javelin trial, it is seen that the best outcomes after the platinum and nivolumab, so the best outcome is with EV ADC, and there's a 40+ month survival from first line chemotherapy regime. So safety experiences in these three, if you see, the long-term safety of avelumab first-line maintenance was consistent with the earlier analysis, with no new safety signals identified with longer treatment duration and maintained patients' quality of life. The long-term safety profile of avelumab first-line maintenance supports continued treatment until disease progression. And among patients treated for more than 12 months, around 75% of available patients reported no change or a decrease in the treatment side effects throughout 24 months of the treatment. So the treatment-related adverse events in all treated patients, if we see more than grade 3 toxicities is around 62% and leading to discontinuation in 11% in Nivo GC as compared to the GC where it is 52% and 8%. The EV302 safety patient with any grade adverse event is 97%, and that leading to treatment discontinuation is around 35%. Treatment interruption in 68% and dose reduction in 40%. And diabetes, we say India is called as a capital of diabetes. Hyperglycemia monitoring may be very much crucial in this. And if we see the discontinuation rate is highest 35% in the EV302 arms as compared to 11% in the Javelin and 21% in the CheckMate trial. So the overall survival, the first line avelumab maintenance therapy and second line EV leads to higher OS. You see that with Nivo GC, it's only 7.9. Survival time after first line is 13.8. So total something around 21.7 months. With Javelin, it goes to 29.7. If they are all patients, with the cisplatin patient, it goes to 31 months. The EV302 further gives a survival similar 31.5 months. And in the Evidence study where you add after avelumab maintenance, the antibody conjugates, the survival may go to 40.8 months also. So the treatment landscape of metastatic urothelial carcinoma is evolving. Maintenance avelumab significantly increases the overall survival to around 30 months. Nivo plus GC, although a positive study, but results in a very minor increment in PFS and OS. Pembro plus EV data looks good, but one need to be cautious with the toxicity profile. And finally, sequencing of available option is the key. EV after first line avelumab maintenance results in unprecedented OS of around 40.8 months. With this, I like to end. So thank you.
Thank you, Dr. Ahmed, for your excellent presentation. Now I would like to invite Dr. Gunjesh Kumar Singh for his closing remarks. Over to you, Dr. Gunjesh.
So thank you so much, Dhruv. Thank you so much, Horizon team. Thank you so much, Dr. Tarun sir. So thank you so much, everyone, all the faculties, all the colleagues from DMH, from Bihar and Jharkhand, from other states, from Hyderabad, and We learned a lot from you and hope we will conduct a similar kind of webinar in future also. Thank you so much and good night to all of you.
Thank you so much, all of you, for joining this insightful webinar. We appreciate your time and participant. Looking forward to see you in future sessions. And special thanks to our sponsor, BMS, Dr. Reddy's, Adley, and Zydus. Thank you so much, sir.